Thank you very much, Chris. And our last talk in this session is for another implementer, in some sense, Augusto Rendon from Genomics England. He's come to Genomics England via Columbia and is the Chief Bioinformatics Officer of Genomics England.
You just give me a raise. Okay. Thank you, Ewan. Ewan sits in our board, so I hope someone heard that. Good. So I will try to be brief. As Ewan mentioned, I look after bioinformatics for the program. I primarily responsible for the processing and management of genomic data, as well as the development and operations of the systems that we use for returning results to patients, interpreting those genomes, and interacting with the clinics to make the best out of that. So I must confess I have been terrible in our group implementing standards, and we've developed a whole bunch of things. So I could probably talk about what not to do. I will show you this slide not to brag about it, rather than just to show you a gap that I get told of all the time about, which is that while we have a lot of samples and most of them have been sequenced, we've only returned results for about a third of them. And the reason behind that, I would claim, is that in the project, because of a number of reasons, maturity, the quickness in which we had to start returning information, we have a gap that is due to fragile interoperability. That means, as I was just saying, evolution of the interoperability specifications between the various systems. How do you get data from clinicians or from their health records? How do you pass the data from one system to the other? How do you interpret those data and pass them to a decision support system? And that has been evolving, and so we're always in a state of flux with that, and has caused, in some ways, a delay. That is flowing now nicely. We can do about 1,000 per week, families per week, and so it's kind of resolved itself. Another reason is the specification was not good enough, and so when I look at previous speakers, they put certainly a lot of effort, and GA4GH2, about thinking about the standards and saying, this is a really solid standard now, it is hardened, and while I might need to go through an activation barrier to learn how to do it, it makes sense to adopt it, because otherwise I will end up with a whole bunch of other problems that you don't have to go through. Big one is, of course, you don't have the systems to enforce the specifications, so your data is not as accurate as possible. So what I'll tell you about is about the two main things that the project does. One is clinical and one is research, and how we think about, say, interoperability specifications, APIs, and ultimately standards. So this is rather architectural view, and I should have drawn this better when I did it the first time, so that because I knew I didn't know that I would have to present it later on. But let me tell you what this is about. This is how we have set up a platform to return interpretations, or better said, to enable the hospitals to interpret the data, to do the variant classification, to ultimately return to patients. So on the left here, there is genomic data and patient or family-based data. There's pipelines that go through that. And the way we think about the process is we throw at a thing called an interpretation service, an interpretation request. That is a number of variants and some information that is derived from that. They do their interpretation. This tends to be, well, up to now, there's just computers that are providing automatic classification and prioritization, and they return something that we define and we call an interpreted genome. We aggregate those sorts of things, and we put it in another protocol, which we call an MDT delivery, as well as the variants, that goes into a decision support system that is simply an application of which we have worked with 3 companies to use them. So we have 3 of those that displays the variants, allows clinical workflows at a lab to classify those variants, generate reports, and document and minute those decisions. To support that, there's a number of API and exchanges, for example, to have variants for confirmation, to have the full set of results, and that finishes with a candidate clinical report. And there's a reason why I'm explaining this. It's kind of, then they can get those clinical reports rendered at any time. We also ask them, them being the hospitals, to formalize what we call an outcomes questionnaire, right? That says, what variants did you end up using, if anything? What part of the phenotype? What classification of that variant? What was the impact to that family or that cancer patient? So we have set up a platform to do that, and of course, you need to have all this data modeling. We've done that over time. They're freely available. Where we're going next is on this side of things. That all sounds very custom, and so we're implementing a FHIR set of resources to be able to get at least those clinical reports, those outcomes questionnaires. There's a lot of data in here in the meantime that is used for databasing and for other purposes. So that is all to say that we've put a lot of effort. Had there been lots of these things existing, or at least had we known about it, we would have started from standards. Just to give you an idea of what some of those models, they do exist. You can go to that website to get a documentation. I think as a minimum, it's a good set of use cases and kind of prototypes that we can work harder with the rest of the standards community to show what we've done, where we have made mistakes and so on. We've evolved them over time as we have gone. So we have models for, as I mentioned, requesting a genome to be interpreted, and that's this case here. Things around the pedigree, the genomic data, and so on and so forth. What is an interpreted genome? And that's just a collection of groups of variants that are associated with groups of phenotypes with some levels of evidence or scores or so on. It's quite general. How do you submit that to a decision support system? And as I mentioned, we have 3 decision support systems already from Illumina, Congenica, and Fabric that implement these APIs and models. And display them and so on. So we're very happy to engage with the community. I think I haven't done a very good job at trying to bring this to the various meetings, and after the previous speakers, I'm quite inspired to try to do that a bit more. Let's switch to research use cases. So another part of the founding principles of the program was to make all this data we've collected available for research, and that's just a recent snapshot or where we are. We have researchers that have sought access to the data from 300 institutions across 24 countries, most of them, of course, UK academics, but there are people from all the countries. We do have a number of clinical users and so on. So you might know from having heard from previous versions of what we have done in Genomics England, our research environment is where you come and do this work is not connected to the internet. You have to access it through a remote desktop environment. However, if you happen to go through that, you can access to a lot of data. You'll have, you have access to lots of genomes, lots of that primary data we've been capturing from the clinicians. We have collected, or we've requested secondary findings from sources, in our case NHS Digital, such as hospital episode statistics and so on. The point being, there's a lot of data, but as I said, you have to access it through a remote desktop environment. Now, our remit is not to lock the data, it's really to make it available for research. However, for reasons that predate the program around patients, I don't know if you've heard about care.data, patients being concerned about their data being sold and so on and so forth. We decided to put in our protocol that the data would be kept in a data center where it could not exit without very clear protocols. And so that brings us some barriers for adoption and usage. And so we have felt the pains of the things that the working groups are developing, and I just wanted to point that out to you. So the first one is, how do you bring in researchers? I just mentioned a few hundred researchers that have to come. You have to grant them access. You have to grant them access to the right resources. They would have had specific access request applications. They all have to be matched to the resources or the genomes or the patients that you have to access. And that's exactly what the Dury group is working on. So that's in the research environments more where we're following those efforts to be able to implement them. And several of us are here and we think, yeah, we need one of those, we need one of those, we need to do that. So if you're in a working group, it's really meaningful what you're doing, and we want to use it. Another problem is You might have a lot of data, I presented in a slide before, but how do you find it? You might have lots of tables that have different nomenclatures of how to look for it and so on and so forth. You want a relatively easy way to discover, get quickly to the types of patients that you're after, get those data and start processing them. The next one is, well, I cannot bring my tools directly to the data center through just a scopy, if you're familiar. You have to bring it through another mechanism. That's precisely the type of things that the clouds people are doing, and we've had a very first prototype of how you can bring a Docker workflow and put it into the research environment that's working now. Lastly, how do you represent and model clinical features consistently so that, again, you can go through a variety of tables and data and say, oh, I know what that means and how I should use it. So we're really trying to adopt all these standards in the research environment. We're just a little bit behind. And that's just to say that by doing so, we really want to maximize the chances of making that data helpful for everyone. It's not for us to keep behind. So that was on those two sides. We have a number of emerging initiatives that we hope we can help steer moving forward, and that I think they're quite important use cases that we all benefit from. So the first one, and other people have spoken about this, Sornitza Stark from the Australian Genomics Health Alliance. Heidi has Reem also spoke about some of these aspects. And the first one is, we all have somewhere a panel, and that is a set of genes that's associated with a condition, and that requires quite heavy curation. So we are proposing with a number of other parties here to set up a network where the curation efforts and those panels themselves can be shared. We have made available this Panel Lab tool some time ago. We're open sourcing that, but also we want to establish the ability to notify other panel repositories. I have put some effort in curating some genes. See if this is useful to you. The second one, which is even more dear to my heart, is this idea that we talk about networks of data silos and sharing and beacons and so on. And I still feel that we haven't really nailed the clinical use case, which is I am a clinical person. I have a case in front of me. I'm trying to make some decision on a variant that is in front of me. We have all collected this patient's information and genomes across the world. How do I get to that? I don't really want to go to ClinVar and see what lab, I think this is Heidi was talking about, see what lab had entered that variant, write to that lab an email, get it back, decide whether it was worth the 2 months of waiting and email negotiations and so on. I would really like just to hit search in the network, who has this variant, who has cases with this variant, tell me how many, roughly, basically beacons at that point, and then point me to the website so I can go and explore further those cases. And I'm not talking about here's a variant with a pathogenicity statement, but here are the 5 cases with their phenotypes, the variants, the other variants that we're seeing in that case, and let me make a decision. So actually, we are late for that meeting. We were going to have it over lunch. But I think if we can use a lot of what we've developed within the Global Alliance, within the beacons and search and so on, to enable such a network for clinical purposes, I think we would have gone really far towards solving some of our founding use cases. So I showed you kind of version 1 from next year, January. We're going to go to version 2. You might have heard that England is moving to or has moved since the 1st of October to a national genomics service. We are building the informatics part of that for the country. And this is just a snapshot. I won't go too much into detail, except to say that on the left, we have a number of arrows interacting with clinics. There's lots of arrows moving samples around. And as we're building this, we're doing that primarily with FHIR and HL7 resources. Same on the research side, we're trying to expose most of our data also through FHIR. In the genomic side, we are adopting quite a lot of the GA4GH standards. So now that we have explored and understood the pains and use cases, I think we feel more comfortable to move to a more standards-rich environment. Let me just finish by saying, I I found that last night we have a new shareholder, the Secretary of State for Health, Matt Hancock, started, I think, 2 months ago. And he outlined in a speech to the NHS Expo. This is where he tells his new, the NHS is the new head of all of this. What is his vision for the future of the NHS? And he's talking about a tech-driven NHS. There's many quotable elements there. You're welcome to have a look at the speech. But here's one that I thought was quite nice. He's talking about how the importance of interoperability, and he's saying where interoperability has worked in other places and the learning from that, the center has imposed strict mandated open standards for interoperability of systems, which in that speech to everyone in NHS is saying, in English, only systems that can talk to each other can be used. So now, from now onwards, that's what you should all be doing. So this is what we're going to do in the NHS. I think that's a quite nice thing to aspire and to get us moving. Thank you very much. Do you want us to sit?
Thank you. We just don't have time for questions, and I'm really sorry about that. So I think we should head for lunch, but please, if you have a burning question, capture those speakers and hassle them. I thought that was a very, very interesting session on the standard setting landscape around us. Great. Yeah, and we meaning at what time do you think? 5 minutes to 2. Yeah. 5 minutes to 2, yeah.